Hi, I'm Rebecca Arujo, contributing writer for DocWire News, and I'm here today speaking with Dr. Andrei Iagaru, Professor of Radiology and Chief of Nuclear Medicine and Molecular Imaging at Stanford Health Care. We'll be talking today about PET imaging for prostate cancer. Dr. Iagaru, you recently had a review published in Current Opinion in Urology that explored the clinical applications of fluciclovine, choline, and gastrin-releasing polypeptide receptor targeting PET imaging for prostate cancer. Could you give a brief overview of the clinical use of these imaging agents?
Yes, Rebecca, very nice to meet you, and please call me Andrei. A small correction, it's not polypeptide, it's peptide. That was a typo that hopefully the publication will get it. This was part of a series of articles in a supplement that were looking at ways to image prostate cancer. Of course, these days, prostate-specific membrane antigen is the universally accepted standard of care, even before it's FDA approved. And at my institution, we use it in research trials where participants don't have to pay for their enrollment in these studies. However, given how complex the prostate cancer is, like any other cancer, and despite how good PSMA is, we must have access to other targets for imaging and hopefully treatment of prostate cancer as well. So we have access to, in the United States, to oxamine, fluciclovine, which is FDA approved, and it works well. In some instances, it may outperform occasionally PSMA, although in many cases, PSMA has been shown to be superior. Historically, choline, which is incorporated metabolism of cancer cells overexpressed in prostate cancer, has been used initially labeled with C11, carbon 11, but also with fluorine 18. So like many of these, including prostate-specific membrane antigen, you can deal with a misnomer because it's not prostate-specific. It's overexpressed in prostate cancer, but other entities can show this target as well. So my view is that the more biological targets we have access to, the better our patients will be served. And gastrin-releasing peptide receptors are a similar biological target that allows us to interrogate yet another component of cancer metabolism. These receptors are overexpressed in 60 to 100% of prostate cancers, but also in more than 80% of estrogen receptor positive breast cancers, ovarian cancers, GI stromal tumors, and others. So I don't think we have a silver bullet in PSMA. We have a great agent in PSMA, but we need to be ready to interrogate the cancer processes when PSMA is not useful.
What are the challenges to PET in other types of imaging for prostate cancer?
Before the introduction of PSMA, prostate cancer was a difficult one for nuclear medicine in the sense that the standard of care, FDG, the workhorse of nuclear medicine in the United States, was only useful at very advanced stages. The aggressiveness of the tumor was much increased. With the availability of C11 choline at several centers, the pioneer in the US being Mayo Clinic, afterwards with oxamine availability, the difficulty in prostate cancer and PET is becoming more a regulatory one. Let's get approval for PSMA, and I think there are good news coming from that direction. And then the reimbursement. We have a big issue here where after the initial pass-through period where post-FDA approval, the cost of the drug is covered for a number of years. Afterwards, it's bundled together with everything else, and institutions are losing money by offering this because they have to purchase the agent from a commercial radiopharmacy and they only get reimbursed for a certain part of the exam. And here is where advocacy from physician organization, patient groups, may result in legislation that will hopefully fix this issue.
What are some other areas that are being researched in prostate cancer imaging that are of interest to you?
So at my institution, we have several trials where we want to expand the use of PSMA as well as GRPR imaging beyond biochemical recurrence and the pre-surgical setting, which are the two indications that have been submitted for FDA approval. We have trials where we evaluate both PSMA and GRPR PET to guide biopsy in men whose MRI are equivocal or negative, but they have high suspicion for prostate cancer. That's an area of unmet need. These men undergo serial imaging procedures, sometimes multiple biopsies, chasing where the PSA is coming from. And our preliminary results indicate that this combined approach may help the urologists guide their therapy. We hope to have preliminary results published soon from our pilot phase study. We are also using the combination of PSMA and GRPR imaging to guide targeted therapy, such as high-intensity focused ultrasound or high-dose rate brachytherapy. The high-dose rate brachytherapy trial is supported by an R01 from the National Cancer Institute. In addition to guiding this local therapy, we also repeat the scan 6 months after treatment. The hope there is that if we can show a decrease in signal on PET, perhaps some of these men will not require a rebiopsy of the lesion to demonstrate success of treatment. A limitation of MRI is in the post-treatment setting where inflammation, bleeding, etc. may make the interpretation more difficult. So I hope the combination of these two biological targets and PET together with MR will allow us to have a more accurate guidance of treatment and a better evaluation of response to treatment.